Good afternoon, everybody. We've been seeing the complications. Fortunately, a guide-induced ostial dissection of the coronary artery has not been addressed. So we'll talk about this complication in the next 10 minutes. Now, incidentally, ostial dissections with a guiding catheter are more common in the right coronary artery. This was a 52-year-old male, again more common in females normally, recent infarct, thrombolized with good resolution of ST changes. An angiogram done the next day showed LED, the left main LED and circumflex non-occlusive plaques in the left circulation, but obviously little diffuse disease everywhere in the coronaries. And this is the right coronary artery. For an interventionist, a very discrete lesion in the mid-RCA. But if you actually look into this coronary artery, this is actually a diffusely diseased coronary artery. And if you do an IVUS in such a patient, you will find no millimeter of the coronary artery which is free of disease. But to an interventionist, this appears a discrete lesion, and that is what we actually would do a discrete stenting of this right coronary artery. This was a simple lesion. The right coronary itself is a decent curve. It's a young patient, no calcium, recent MI, so a soft lesion. So all characteristics of a straightforward, simple angioplasty, discrete angioplasty to the RCA. So the patient was taken up for an angioplasty the next day. We do radial procedures, so, and as a routine, we use the RRD, the right radial guiding catheter for most of our angioplasties for the right coronary artery. And immediately after cannulation, this is the first injection. So you have a spiral dissection right from the ostium of the right coronary artery extending across right up to this bifurcation. Now, what do? The patient did have transient hypotension, bradycardia, which was, with fluids and some atropine, he was resuscitated. There was chest pain, but hemodynamics settled down. He gave us time. So what would you do here, So basically this dissection...
The operator had more chest pain than the patient.
Pardon?
The operator had more chest pain than the patient.
Exactly. When you see something like this, and this is, as said, if a spiral dissection caused by a balloon dilatation, when you have a wire across the artery, is very simple. You just have to put a few stents. Here, you don't have a wire across the coronary artery. So what do you do next? This dissection has been caused by this guiding catheter. This was a RRD, a right radial catheter, a little more traumatic catheter than a simple right Judkins catheter because it goes deep inside the artery. Possibly this artery was diseased, so this catheter abuts onto the vessel wall, and you possibly have injected into the intima and caused a dissection here. So what do you do next? Do you take a wire straight away and go down and try to go into the true lumen? My suggestion in such situations would be either change the guide or at least get this guide out into the cusp, the right coronary cusp. For two reasons, or if you don't want to change the guide for some reason, at least change the orientation of the guide and get it to the ostium. And this is what we did. We changed the guide to a right Judkins, got it to the ostium. Another advantage of getting to the ostium is the force with which you inject now is much less. Each time normally, if you inject after a dissection, you tend to extend the dissection. Here, incidentally, the dissection was right there, so I think whether that would make a difference or not, I don't know. But when you have a dissection which is not right across, it is always good either not to inject or inject very slowly into the coronary artery when you have caused an ostial dissection. So, and this is a regular workhorse wire. Another thing is use your workhorse wires which you are comfortable with. And this was, I think, either a run-through or a Renato wire, which is our workhorse wire. It easily went across down into the corner without any resistance, with minimal manipulation. It is into one of these branches. There's a small branch here. So things look all right. It is into another branch, There's a branch here, so it's gone into another branch. Now, as you see, the dissection is right up to the PLV, the distal PLV. Earlier, we thought it was up to the bifurcation, but now it's right up to the PLV. And now this wire has gone into the distal PLV. So a small branch here, a bigger branch here, and into the PLV. I think most of us would be comfortable here that yes, we are in the true lumen and we can now stent. But somehow this wire did not go into this PDA, which, and I knew that this dissection is right up till here. So since it was not going into the PDA, I was not very comfortable still that yes, it is into the true lumen. I took another wire, gave a little more angulation at the tip so that to facilitate it's going into another side branch. So here, as it entered, it went into one of the small conal branches of the RCA. So now I knew it is into the true lumen for sure. And then we tracked this wire down. As you see, it goes down again into the same branch, into the PLV, goes there. We inject a little, again injection mostly outside the ostium, get the wire back, and now this effortlessly goes into the PDA. So now we are certain that yes, we are into the true lumen for sure. We remove the other wire now, and now we are ready to stent. Again, the issue would be whether I just stent at the ostium or we start stenting from distally up. So, since this is a ostial dissection, if we seal the ostium, the opening entry point of the dissection, most of the time the distal would automatically close down. So there was a lesion in the mid segment, so we took a longer stent. This is, I think, a 3 by 44 biomine stent, which went across here. As you see, such a long stent went through a simple right Judkins catheter, not requiring much support. So our choice of a RRD, which gives more support, was not really a good choice. So in simple lesions where you don't anticipate problems, you should take those catheters which are least traumatic. So after that, it was we dilated. So everything was flowing well. Another post dilation, the same balloon pulled a little back at high pressures. And you see the dissection is taken care of, the mid lesion is taken care of, and the distal flow is well established. There is some, but I'm sure this would go away. Everything went off well after this. So a few learning points. Number one, choose your guide carefully. And a more traumatic guide was not necessary. It was a discrete lesion of the RCA. We could have started off with a right Judkins guiding catheter. Second, whenever you engage your guide, always look at the pressures. Never ever inject when the pressures are dampened. It could be a spasm, it could be anything, but never try to inject whenever there is, whenever your guide, you're not getting adequate pressures. Because if your guide is abutting into the ostial plaque and causing damping of pressures, an injection is going to cause a dissection because you will inject into the intima then. That's possibly what happened in our case. So always take care of that. And if dissection is visualized from the ostium, preferable to change the guide or at least change the orientation of the guide. Try to get the guide into the cusp of the coronary artery. Cuspal injections, and don't inject or inject very slowly. Use cuspal injections and try to enter into the true lumen. Use the workhorse wire which you are comfortable with. Again, avoid using the hydrophilic wires because they would tend to go anywhere and you lose the distal tactile feel with these hydrophilic wires. Side branch entry confirms the true lumen, but don't be happy with just entering into one side branch. Yes, if the dissection was just at the proximal contained portion, the distal artery was looking good, then distally one branch would have satisfied me. But if it is dissection like this, you should be certain that it goes into multiple side branches. And usually, in such ostial dissections, just sealing the entry point with a stent would solve your purpose.